All right, guys, so in this final voiceover, we're going to talk about chronic kidney disease and end-stage renal disease, renal replacement therapies, so dialysis, and kidney transplantation. Chronic kidney disease is the progressive, irreversible loss of kidney function. Risk factors for developing chronic kidney disease include diabetes and hypertension. These are the two leading causes of chronic kidney disease. Other risk factors include cardiovascular disease, being over the age of 60, having a family history of CKD, exposure to nephrotoxic drugs, so drugs that are toxic to the kidneys, and being an ethnic minority. African Americans and Native Americans are at higher risk of developing chronic kidney disease. Chronic kidney disease is more common than an acute kidney injury, and patients are often asymptomatic, so chronic kidney disease is often underdiagnosed and undertreated. There are 5 stages of chronic kidney disease. Stage 1 is the most mild, whereas stage 5 is the most severe. When patients enter stage 5, they have end-stage renal disease. At this point, they require either dialysis or a kidney transplant in order to sustain life. For stages 1 through 4, the goal is to try and avoid the need for dialysis or a transplant for as long as possible and preserve kidney function. During these stages, we'll help the patient control their chronic diseases like hypertension, diabetes, and anemia. Because chronic kidney disease can be asymptomatic, patients are not usually diagnosed until more than one of their body systems is affected. This slide comes directly from your book, and it shows you the possible clinical manifestations of chronic kidney disease, and you can see that there are quite a few. Patients won't always go through all of these symptoms, but they tend to have quite a few of them. Chronic kidney disease mineral and bone disorder, or CKD-MBD, is the most common complication and manifestation of chronic kidney disease. So we're going to go a little more in depth in regards to osteoporosis and its relationship with end-stage renal disease. Due to deteriorating kidney function, patients will often have a low vitamin D and calcium level and a high phosphate level. This combination will lead to stimulation of the parathyroid to remodel bone and increase the serum calcium level. The problem with this is that the accelerated rate of bone remodeling causes weakened bones and puts the patient at an increased risk for fractures. CKD-MBD causes soft tissue, vascular, and skeletal complications, including osteoporosis. So treatment for this is typically giving the patient phosphate binders because they help pull phosphorus into the bowel to be excreted in the stool. Different phosphorus binders included on this slide are Oscal, Foslo, and Renagel. It's important that when patients are taking phosphorus binders that they understand that they need to take them with meals. The dietary management for chronic kidney disease is complex and very hard to follow, so noncompliance is a very common issue. The rules are highly different from standard dietary instructions, and these patients need to understand that they have to have a low sodium, low phosphorus, low potassium, and low protein diet. When they do have protein, it needs to be high quality protein like lean meats, fish, and egg whites. Oftentimes, patients will also be on a fluid restriction, and if the patient is on hemodialysis, the restriction is far greater than if they're on peritoneal dialysis. It's important to note that every patient's diet plan is unique to them. These are the most common recommendations, but patients will create specific diet plans with the help of their nephrologist and their nutritionist. Client teaching with chronic kidney disease and end-stage renal disease can be complex, so there's a lot that needs to go into it. You need to make sure that you're educating your patient about their dietary restrictions. So remember that low sodium, potassium, phosphate, and protein diet, along with their individualized fluid restriction. You want to teach them to report signs and symptoms of electrolyte imbalances, and one of the worst imbalances they can have is hyperkalemia or high potassium. So things that they need to be told to look out for are tiredness, nausea, vomiting, any trouble breathing, or chest pain. We also need to teach the patient on when to report signs and symptoms. So any weight gain greater than 2 kilograms, it's about 4 pounds, shortness of breath, increased edema, fatigue, or confusion. We also need to provide education about follow-up appointments and referrals. The dialysis schedule in particular, frequently patients are going for dialysis up to 3 days a week, 3 to 4 hours at a time. So sometimes it's really hard for them to get back and forth to the appointments, so we need to make sure that they have adequate transportation. So now we're going to talk about renal replacement therapies, also known as dialysis. And there's 2 types that we're going to talk about, hemodialysis and peritoneal dialysis. Dialysis is the movement of fluid and molecules across a semipermeable membrane from one space to another. Dialysis is used to correct fluid and electrolyte imbalances and also remove waste products from the blood in patients who have kidney failure. The criteria for beginning dialysis is different in every patient and is ultimately up to the nephrologist on when the patient needs to start, but usually the determination is based off of lab work or the severity of the symptoms. Patients can have uremic complications like encephalopathy, neuropathy, uncontrolled hyperkalemia, pericarditis, and accelerated hypertension. All of these complications lead to an immediate need for dialysis. There are 3 reasons why a patient is on dialysis. Either there's someone who is not a candidate for transplant, so they're not going to do well and the doctor has already determined that that's not an option for them. There's a shortage of organs, or the patient just does not want a transplant. I've included a link in the notes section of the slide to a YouTube video, and I think it does a really good job of showing and telling you about both peritoneal and hemodialysis. For a patient to be on hemodialysis, they need to have some sort of vascular access. Patients can have arteriovenous or AV fistulas. These are the longest lasting access, and they're also the preferred access. An AV fistula is surgically created, and it connects a vein and an artery. Once it's created, it can take up to 6 weeks to use because it needs to mature. And what I mean by that is it needs to get large enough in order for it to be used effectively. The important thing about an AV fistula is that you need to understand that you need to make sure you're assessing for a thrill and a bruit. A thrill is the buzzing feeling you have when palpating the fistula, and the bruit is the rushing sound you hear when you use your stethoscope. They commonly say that you feel the thrill and hear the bruit. You need to be always checking the bruit and thrill when you have a patient with a fistula. Patients can also have grafts if the fistula is unsuccessful, because it's preferred to have a fistula. Grafts are made of synthetic materials, and they create a bridge between an artery and a vein. You need to give a graft about 2 to 4 weeks to heal before you use it, and there's a higher risk of infection involved. Both an AV fistula and a graft have a risk of being infected or being occluded, which means clotting off, so that's why you need to be frequently assessing them. Patients can also have hemodialysis catheters. Short-term patients can have temporary catheters put into their jugular or femoral veins, and those are used for immediate dialysis access. So these are patients that can't wait for an AV fistula to mature. They need dialysis right now. Both a temporary and perm cath are going to have a dual lumen, one for the inflow and one for the outflow on the dialysis machine. There's a higher risk for infection with the temporary catheters as opposed to the long-term. The long-term catheters are also called perm caths, and patients can be discharged home with these. They can be used for a short period or a long period of time. Patients who have exhausted all other access sites, so they've had a few AV fistulas created and they've all failed, and they aren't a candidate for a graft, the patient can have an HD catheter placed for long-term management. Before a patient receives a hemodialysis treatment, we need to assess their fluid volume status. So we need to be checking a pre-dialysis weight, checking their blood pressure, assessing for any peripheral edema, evaluating lung and heart sounds, and assessing their vascular access. So assessing their fistula or their graft, checking for that bruit and thrill, assessing their HD site, whatever that may be. So we also need to check their temperature to assess for any signs of infection. During dialysis, we need to assess the patient's vital signs frequently, so about every 30 to 60 minutes, because they can have rapid changes in their blood pressure. After dialysis, we need to get a weight to see how much the patient has lost. We should recheck their vital signs. Following a dialysis treatment, patients are often fatigued, have orthostatic hypotension, and possible muscle cramps, and these are all expected findings. We need to be holding meds until after treatment unless otherwise ordered, and there should be absolutely no blood pressure, blood draws, or other procedures on the arm with the AV fistula or graft. Some complications of hemodialysis include hypotension, and that's because of the rapid removal of fluid with this specific type of dialysis. Muscle cramping, it's unknown why exactly this happens, but patients can have a loss of blood, and they're also at a risk of developing hepatitis. Patients with end-stage renal disease can also be on peritoneal dialysis. With peritoneal dialysis, waste products will cross that semipermeable membrane into the peritoneal space, so that's where the exchange or dialysis occurs. Surgically placed catheters that are flexible are inserted into the abdominal wall for this type of dialysis. After a few weeks, fibrous tissue grows around that catheter, holding it in place. These can be used immediately after being placed, but for low volume exchanges. So you don't want to pump that full 2 liters in right away, you want to give it some time to heal. Patients can shower once healed with this catheter. You also need to make sure that with this type of catheter and this type of dialysis, that you're teaching your patient to look for signs of infection, which we'll talk about in just a few more slides. Some patients don't use a dressing on the PD catheter, so you may see someone admitted to the hospital who doesn't have a dressing in place. Peritoneal dialysis is accomplished by instilling dialysis fluid into the peritoneal space. There are 3 phases of PD: the inflow, the dwell, and the drain. The inflow takes about 10 minutes, but can be shorter or longer depending on your patient. The dwell varies based on physician orders, but is typically between 4 to 6 hours, and the drain takes about 15 to 30 minutes. There are two different ways that we can perform PD. Continuous ambulatory PD, also known as manual, is done throughout the day. So the exchanges occur every few hours, usually happening about 4 times daily, but again, can be different based on what the patient needs are and what the nephrologist has ordered. The other type of dialysis is continuous cyclic PD, and this occurs while the patient is sleeping. So they have a machine at their bedside that will do the exchanges throughout the night for them. The advantage to this type of dialysis is that the patient does not need to do exchanges during the day, so this gives them a little more freedom with their dialysis. With both types of peritoneal dialysis, aseptic technique is critical because there's so many different complications that can occur, but the most common complication is peritonitis. So just like there are disadvantages with hemodialysis, there are of course disadvantages of peritoneal dialysis. As I mentioned in the previous slide, the biggest and most common complication that PD patients are at risk for is peritonitis. And what that means is an infection within the abdomen within that peritoneal space. So signs and symptoms of peritonitis include abdominal pain, nausea, vomiting, diarrhea, rebound tenderness, and cloudy effluent. And what effluent is the fluid that drains in that last phase of the dialysis cycle. So these patients are also at risk for hernias, lower back issues, exit site infections. So we need to not only be teaching our patients about these signs and symptoms of infection, but we also need to be teaching them how to keep that exit site clean. These patients also are at risk for bleeding, pulmonary issues, and protein loss. One of the other disadvantages includes the personal responsibility that the patient has every single day to manage this type of dialysis. On the flip side, that can also be an advantage because a lot of this dialysis is managed in the home setting, so peritoneal dialysis patients don't have to go to the clinic 3 times a week like they would if they were on hemodialysis. PD also requires a dedicated storage and management area. Peritoneal dialysis is inappropriate for patients with limited vision because people really need to be able to see what they're doing and keep things clean. If they have limited vision, they're at higher risk for infection because they're at higher risk for contaminating that site. Patients may be fearful of not being able to perform the task, so there's a lot of education that needs to go into PD so that the patient along with their family members are comfortable and feel confident in performing the dialysis exchanges. All right, guys, so for the last part of our voiceover, we are going to talk about kidney transplantation. Some of you guys may or may not know that I work in kidney transplant, and it's a really cool area of nursing. I get to see and learn a lot of really cool things. So kidney transplant is the best option, the best treatment option for patients who have end-stage renal disease. Unfortunately, fewer than 4% of patients who need a transplant will actually receive a transplant. And that is due, unfortunately, to the very large disparity between the supply and demand for kidneys. So there just are not enough organs to go around for all of the people who need them. Currently, there are over 100,000 people on the wait list, but only about 17,000 transplants will take place each year. The average wait time on the organ wait list is 2 to 5 years. So unfortunately, most people who are waiting for an organ will die while they're waiting for an organ. We see 2 different types of transplant. The most common is a deceased or cadaveric donor, but we can also see healthy live donors, which is great. One of the big advantages of kidney transplant is that it does reverse many of the complications that are associated with renal disease. It's important to remember that kidney transplant is not a cure for end-stage renal disease, but it is a treatment. So it's a very beneficial treatment. It also ends up being, after the first year, a less expensive treatment option than dialysis. So for our patients with end-stage renal disease, transplant is a really, really great treatment option. There are two different types of kidney transplantation, live donor and deceased donor. Deceased donor is when someone who was an organ donor dies and is declared brain dead. They will have their organs procured, which means taken out, and given to someone who was on the UNOS waitlist for a transplant. Live donor, on the other hand, they go through pretty extensive screening to be ruled as a good donor for somebody. So it can be a relative, a non-relative, or altruistic, which means it's an anonymous donor. And we've actually seen a couple of these done at Albany Med. The live donors will give one of their kidneys to the recipient. So there's a lot of ethical considerations that are involved with live donation because you're taking a healthy person, cutting a very large incision, and removing a kidney in order to help someone else. So there's a lot that goes into it. The recipient needs to be screened as well to make sure that they'll be compliant with the transplant regimen because it's very intense, especially when they're discharged on numerous, different new medications and being compliant with the meds. And then the UNOS waitlist, that's the database of all of the people who need kidneys. And UNOS is in charge of distributing those deceased donor kidneys. So they're the ones who reach out to say that a kidney is available when a donor dies. Immediately post-op, transplants are often placed in the ICU setting for close monitoring, but this is different with every program. We need to make sure that we're assessing the dressing in place over the transplant site for any shadowing, and we also need to see if that dressing is becoming loose. We need to look for signs and symptoms of rejection, like fever, edema, and hypertension. These patients are at a huge risk for infection because of the immunosuppressant medications that we're giving them, so we need to be assessing drainage and monitoring for any fevers. We also need to be limiting visitors because we don't know if a visitor is sick or even a staff member, so you need to really protect your patient from infection. The golden rule is usually to have no more than 2 visitors at a time. We need to be doing strict intake and output to assess renal function. So these patients are going to have frequent lab work to assess that function, but they're also going to have a Foley catheter in place to accurately monitor intake and output. Discharge teaching is huge with transplant patients, and it's a specialized field, so usually there are teams that will provide education to the patient about discharge teaching because it's a huge lifestyle modification. We need to be teaching the patient about their anti-rejection medications and taking them exactly as ordered, because if they aren't taking them exactly as ordered, they're at risk for rejecting and losing the transplanted kidney. We need to teach them to monitor for signs and symptoms of deteriorating function, so they'll be monitoring urine output, intake of fluid, what they're eating, their finger sticks if they're diabetic, and their vital signs at home. So we really need to be cognizant and well aware of what it means to reject and when they need to call us. Pain over the transplant site is one of the first signs of rejection. They need to be informing all of their healthcare providers about their transplant, especially when they go to the dentist. They need to explain to the dentist that they're a transplant patient because oftentimes they'll be put on prophylactic antibiotics to prevent infection. They need to avoid exposure to infection, so especially for the first 6 months post-transplant, they need to avoid crowds, and also they need to have cancer screenings, these patients, because the anti-rejection medications are really great at preventing rejection, but unfortunately, they're also great at causing cancer in these patients, so they need to have frequent screenings and frequent follow-up appointments.